Okay, we're going to talk about back pain. And you think, wait a minute, ultrasound for back pain? You can't, see inside the spinal cord with ultrasound, and that is true. But what I want to impress upon you is that not all back pain is in the spine. There's lots of other things that can cause someone to have back pain, and that's really where ultrasound can come into play. I will start with this example. This is a real example. That guy right there, that's my uncle, Uncle Doug, Uncle Dougie. Unfortunately, when Uncle Doug was 57 years old, he had an issue with his back. He went into the emergency room near where he lives on the East Coast, and they knew, he had atrial fibrillation. He was on Coumadin, so he's anticoagulated. He's got a history of high blood pressure. He does like the cigars, and you could see that picture of him there. He's not exactly a slim guy, and his blood pressure at the time was stable, his heart rate, everything was pretty normal, and his abdomen wasn't tender, there were no masses, anything like that. They examined his back. This was on a Monday. They examined his back. No midline point tenderness, and he had negative straight leg raises, meaning when they lift up his legs, it didn't he had no shooting pain down his legs or anything like that from his back. Didn't make the pain worse, but he was complaining of back pain. Now, what they did was they gave him some Vicodin and said, well, you probably had a back strain, and they sent him home. And that was on a Monday. On a Friday, he goes back to the same ER. It happens to be the same ER doctor working. And he says, boy, I took that Vicodin and didn't feel any better. I'm still having all this crazy back pain. And so, this doctor's like, okay, drug seeker. Let's go ahead and check your urine. Maybe you got a kidney stone or something. So they check your urine, and he's got blood in his urine. And so they go, well, we're going to get a CAT scan, see if you have a kidney stone. And they do a CAT scan. The CAT scan show he has a 10-centimeter abdominal aortic aneurysm that is leaking. And so he's on Coumadin, as you recall. So they sent him over to Eastern Virginia Medical School, where he goes to the operating room. And he ruptures intraoperatively this 10-centimeter AAA, only 57 years old. And they transfuse him with 40 units of blood. And he's in the OR for 10 hours. It's crazy. And he survives. He survives, goes to the ICU. He lives in the ICU for a month. He gets a peg and a trach and everything, and survived this whole thing. When you talk to him about his experience, he'll tell you, boy, I'm so glad that ER doctor thought to do a CAT scan on my second visit, saved my life. And I'm thinking to myself, had that doctor done an ultrasound on the first visit, they would have saved your life in a way that was a lot less crash and burn, but a lot more non-invasive, like doing something endovascularly rather than this big open crazy procedure. So anyways, he was lucky. Here's another case to illustrate this. This is a case I had when I was a fellow, actually, in Chicago. And so this is back in 2000, 2001, long time ago. 70-year-old guy come in with a choking episode at a restaurant, and they bystander did did a Heimlich maneuver on him, and he comes in, and the paramedic's like, oh yeah, he was choking. Bystander did Heimlich maneuver. He looks pretty good, and the patient's actually sitting up and looking at me. He's like, hey doc, and I'm thinking to myself, okay, probably going home. And then they brought him to a bed, and then 15 minutes later, a resident walks up to me, and they're like, hey, remember that this guy came in with a choking episode? I go, yeah, I saw that guy. He looked pretty good. I go, well, he was at I think we need to change our algorithm from choking to syncope. I'm like, well, why is that? He goes, well, the more I talk to him, the more I realize, he's at a restaurant, and then he tells me the last thing he remembers, he's eating his dinner, and then he's on the ground, and they're doing the Heimlich maneuver on him, and he totally syncopized. I think we got to go down the syncope algorithm. And, of course, anybody who syncopizes, we're looking around for abdominal aortic aneurysms on people like that. So, but even early in my career, I was a little bit like, okay, sure, we'll check for AAA, but, that was a long time ago, and this is an image from a long time ago, and this is that exact guy who had a, quote, choking episode, and you can see this large abdominal aortic aneurysm going on here, 8 or 9 centimeters, and it was, leaking, and this is somebody who went to the operating room and survived. So, yeah, absolutely. This is anybody with back pain now over the past, 20 years of my career, picked up abdominal aortic aneurysms over and over and over and over again. Just had one this last week, actually. It wasn't my case. It was somebody else in our emergency department here at UCI. So the stats on abdominal aortic aneurysms, not good. A lot of, like 30,000 people die a year from these things. Killed Rodney Dangerfield, actually, a famous comedian you probably never heard of. Most commonly in males greater than the age 60 years of age, and there's like a classic triad on the physical exam, something to do with pulsating abdominal mass, hypotension, back pain. It's only present in like 25% of the cases. And what's really more common is that they're basically asymptomatic until they rupture. And once they rupture, they die like 80% of the time, most before they get to the hospital. And if they get to the hospital, about half who undergo emergency surgery die. So again, my uncle's super lucky. And about 30 to 60% of patients are totally misdiagnosed. And this is why like Virchow and Osler and all the greats of medicine would always call this the great mimicker. Or AAA is going to fool you and you're going to miss it and you're going to feel terrible the rest of your career. And it depends how big they are. The bigger they get, the more likelihood of rupture. Once you get up to about 7 centimeters, this is like, you pretty much got to admit these patients to the hospital and have something done for them. A study looking at ultrasound, even before I had my index case on that choking guy, was actually 1998. And it would be unethical to repeat this study in today's literature because we know how good ultrasound is. But basically, these patients got randomized as they were coming in for suspected AAA. And the ones who got ultrasound had a mortality rate of 40%. And the ones who got randomized to non-ultrasound group had a mortality rate of 72%. So you can see why that would be. It's totally unethical now. Dave Plummer et al. There in Minnesota. So, went on to say that ultrasound actually has 100% sensitivity for AAA, and which is like 100% negative predictive value and very limited in terms of our variability. And we need to be considering an abdominal aortic aneurysm in patients who have back pain, abdominal pain, flank pain, thigh, groin, scrotum, buttock pain, patients who are weak and dizzy, patients who syncopize, patients who have in cardiac arrest, and anybody with undifferentiated hypotension. I'm thinking about a AAA, and we're finding them all the time. Now, the funny thing about ultrasound in general, and I like to bring this up, is it's really good to study what a normal thing looks like on ultrasound. I know I've said this before, harped on it, but one more time here. This is how the analogy I make is with the currency and the people who find the counterfeit money. They're not trained in all the different millions of types of counterfeit, money. They're trained in exactly all of the signs of what a normal, note should look like. And in this case, we're looking at a $100 bill, and there's like all these different ways in which it's a legitimate $100 bill. And I like to think about ultrasound the same way. Once you learn what all the normals look like, so don't discount the scanning of all of the normal models that you're doing before you move on to the pathology, because actually what you're being trained to do is to identify what all looks normal, and then when something fits outside that normal zone, that's when you know to raise an eyebrow and pursue it. Hope that made sense. This is what the normal looks like. This is the spine shadow right here. This is the abdominal aorta. This is the IVC over here. Indicators in a transverse view. We're using a curved transducer, or you could use phased. Indicators the patient's right. Therefore, this is on the left side of the screen. The aorta is just left of the spine shadow, and that's really what you got to know. A bunch of anatomy on here I've gone over before. I'm not going to go over that too much, but basically what you're going to do is
when imaging the aorta, orient the indicator cephalad towards the patient's head.
From the head,
this orientation provides a sagittal view of the aorta.
Your sagittal view here.
Sliding the probe inferiorly along the body, you can continue to obtain a sagittal view. You may obtain a nice sagittal view there. The aorta is represented by this non-echogenic tubular structure stretching across the screen.
Here. I'm talking to myself.
By turning the indicator towards the patient's anatomic right, you obtain a transverse view.
You're going for transverse. That tube stretched out, now it's a circle.
Sweeping down toward the umbilicus, you can follow the aorta throughout its entirety. By starting up here, note the spine shadow. Right here. Here's the aorta.
pretty straightforward. This was a case on Catalina that one of my attendings had, and she took this video with her cell phone and just said, hey, I'm looking at a AAA, right? And I said, absolutely. And so, you know, this is, I don't know, 1, 2, 3, 4, 5, 6 or 7 centimeter AAA. And she's using the phased array transducer, again, curved or phased. And I happened to be in Ireland at the time, and we're like FaceTiming through the cross continents, and absolutely this patient was airlifted off of Catalina and came to UCI and had a good outcome. But again, this patient came in with back pain. This is what these abdominal aortic aneurysms can look like here. You can easily pick it off the screen. It jumps right out at you. Again, it doesn't have that tiny little circle standing on top of the spine shadow. Instead, it's a big black circle. This material is all like mural thrombus, probably a chronic one here that just kept growing and growing. But you would measure the anterior, posterior diameter from here down to here. Here's the actual lumen. Another example of abdominal aortic aneurysm here. Again, could maybe miss this one. Say, oh yeah, I see a little circle here. That looks normal. It's normal caliber. But this is actually the entire aneurysm with all the mural thrombus out here. So this is like a 3 centimeter or so aneurysm. You can see as another one here with a lot of turbulent flow. If you put the color flow on it, whenever you see something black on the screen and you're unclear about what that could be, is it a cystic structure? Is it a vascular structure? Cystic structures are usually pretty spherical. Vascular structures will stretch out in a tube, tend to, but the color can help explain that as well, differentiate those two. Just this sort of patterns. This is the transverse view. Here's your sagittal view of that same pathology. You can see, again, the anterior posterior diameter here. Again, all this mural thrombus over here, and then your IVC is seen next to the aorta here in a transverse view. Another example here of a thrombus within the lumen of this aneurysm. So here's the aortic aneurysm here, and this thrombus is moving around. You could see why sometimes the presentation may not even be back pain or abdominal pain, groin pain, flank pain. It might just be a cold foot. We had that recently. Someone came in, we thought it was just some peripheral arterial disease, and then it turned out that it was from a AAA with a clot just like that. And you're wondering, like, what are all these circles on the screen? Here's the spine shadow. What's going on here? There's two types of aneurysms. There's fusiform and the other kind, which this is saccular. So these are little saccular structures here, and I confirmed it using the color Doppler. This is what a saccular aneurysm looks like here. Again, not sure all these black circles are. Color Doppler helped out with that. Very different than this other type of pathology called aortic dissection, where you're getting a dissection of that intimal medial layer here, and you can see this flapping along. So when you have an aortic dissection, the caliber of the aorta appears to be normal, but it's this intimal layer that peeled away, and we're starting to see it flap, this flapping motion here. So if you do see a dissection, this is what they look like here. You can see this this flapping. Now, once it fills in with blood, eventually blood can fill in and coagulate back here and congeal, and you may not see the dissection flap anymore, flapping around. It could be hard to see. So you wouldn't want to rule out an aortic dissection with ultrasound. CT angio is a better way if you're curious about that, but certainly you can rule it in if you see this flap here. Dissection, another example here. Pretty obvious. You see that that flap here, just flapping in the breeze for dissection. Now, what else can cause back pain? Renal problems, right? Like renal colic. And so just to review the normal anatomy here, this is the pelvis or the renal sinus, in the center of the kidney. And when you have a blockage of the ureter, what happens is this area here in the center dilates out. And these are the calyces here, and you'll start to see this pelvis dilate right up out into the calyces. Now, the renal cortex, on the other hand, is seen out here, and this is where the renal cysts tend to be, way out here in the renal cortex. And so on the ultrasound, the cortex is out here, and then the renal pelvis, this hypercoque area, is in here. This patient does not have any pathology. I'm just kind of showing the vasculature for fun. Here you can see the renal cortex. Again, this is some disease seen out here. These are renal cysts, this polycystic kidney, because these cysts are all the way out in the cortex, whereas over here, this is hydronephrosis, which is, there's been a blockage of the ureter. Once in a while, you'll see the ureter on the screen here as it exits out the side. but this is all hydronephrosis or fluid building up in the renal pelvis or sinus. So I like to look at the kidney, the long and the short axis, and I just examine it for any changes in architecture. Here's the upper pole of the kidney here, and this is the left kidney, so this is spleen over here. As I get down to the lower pole, I see what appears to be a mass, and it's a distortion in the renal architecture. And so it's really kind of jumping off the screen at me now, this lower pole mass. Now, I realize that we're really trying to focus this talk on renal cysts versus hydronephrosis causing flank or back pain, but cancer is definitely in the differential when someone's talking to me. And if I just happen to stumble across it with ultrasound, a distortion of the renal architecture, that's when I get very concerned, obviously, for the patient, and I get a CT scan. This was a 5 by 7 centimeter mass once we measured it out, so that would definitely require CT follow-up. So polycystic kidneys, again, spherical structures. As you rotate the transducer from a coronal plane maybe to a transverse plane, these cysts are generally spherical and independent of one another. They do not coalesce or communicate, which is different than hydronephrosis. This is nephrolithiasis. Looks just like a gallstone with a hyperechoic structure, the shadow behind it, reflection artifact. The rib shadow keeps going back and forth up here at the top of the screen. I'm seeing a rib shadow in the way, but this kidney happens to have a hyperechoic with a shadow behind it there. This is what hydronephrosis looks like, and would definitely be causing this patient a lot of flank pain. Patients with renal colic, usually the pain comes and goes. It's very crampy, and they're moving all over, squirming all over the bed in a position that they cannot find comfort no matter where they move. And so you can see renal colic from across the room the more patients you talk to who have it. And every time I talk to a patient with renal colic, I remind myself, boy, I hope I never get a kidney stone because this looks so uncomfortable. But this is the hydronephrosis. The renal pelvis here is dilated from the distal blockade from that stone, and it's kind of marching itself out into the calyces as well. Here's another example of severe hydronephrosis. The cortex is being squished all the way out to the periphery, and the center of the kidney and all the calyces are all kind of coalescing together just to be one giant black circle in the middle in the pelvis of the kidney. Another example here of severe hydronephrosis. Again, the cortex is squished. You're not even sure what organ this is anymore. It's like, wait, is this like the IVC? Is this the gallbladder? What's all this black stuff here? And it takes a minute for you to kind of fan through everything and piece it all together when you do get these severe forms of this pathology. Any questions, of course, you could always CT this. And I like to compare the kidneys side by side. Here's a normal-looking kidney on the right, and this patient, here's their left kidney, and you can see they've got some hydronephrosis here. The machines can all do that split screen there, and I think that can be helpful to kind of compare things. Yeah, this image looks a little too hypoechoic to me. I might bump up the gain to have it look a little better. And then, and so I talk about the bladder. Can also, if the bladder is occluded by all kinds of things, a very large prostate, a stone in the bladder, a mass in the bladder, a FOLEY catheter that's not functioning, then the urine can build up and then ultimately cause post-obstructive hydronephrosis, where the kidneys can get obstructed as well, and that can cause back pain. So this is in the differential. I just want to talk to you about the bladder. By the way, this is a very nice left UVJ, uretovesical junction seen right here with a nice urine jet. Somebody just drank a cup of coffee and the urine jet is just firing away down there. It looks very nice. You can put color on that. It's a lot of fun. The clinical utility, though, of that, I don't know, but it is fun to look at. Here's a bladder mass, which, again, can cause obstructive and post-obstructive uropathy or post-obstructive hydronephrosis. In this case, you can see the mass there down at the bottom of the screen. Again, anything that jumps out of the ordinary for you, normally the bladder walls are very thin, less than a centimeter, and then, boom, you see the structure. When I see that, I go, could be the prostate, could be a bladder wall mass. Looks a lot more like a bladder wall mass to me now that it's really coming inside the bladder, especially if it was not a male patient. This is a bladder stone. You can see the calculus. Again, like any other stone in the body, whether it's in the gallbladder or the bladder, it's very hyperechoic with a shadow behind it. And this is a clogged FOLEY catheter. This patient's got a lot of hematoma in their bladder. Here's the FOLEY catheter balloon, and the hematoma is causing, the hematoma is not able to be drained through that Foley catheter, and so the bladder is actually pretty full of clot in it. This would require someone to come and flush and do a lot of washings or even cystoscopy to break up that clot and get it out. So, but that would be another cause of back pain. Believe it or not, when these bladders fill up and they obstruct with clot, then the pain can start in the back where the kidneys are obstructed. Another sort of bladder hematoma that's sort of organized down here in different stages of coagulation, hyper and hypoechoic areas to it. But this is what a bladder clot. I know it looks a lot like a mass too, you're wondering. A lot of nice posterior acoustic enhancement here as well. To differentiate the two, you could put a Foley in if you saw a bunch of blood start to come out, then you'd for sure know that you'd be more concerned about that being a clot, not a mass. But ultimately, CT scan would clear that up as well. But you did get to the diagnosis of why this patient's having all this uropathy or obstruction. Bladder diverticulum. So somebody who has like chronic UTIs, or maybe has chronic Foley catheter placement, their bladder's walls can get really thin. Or somebody who has a neurogenic bladder, this can happen too. Their bladder walls get really thin, and eventually, this is actually the patient's bladder here. It's pretty much empty. The bladder wall here is very thickened from chronic UTIs, but there's been a chronic UTI here, neurogenic bladder, multiple Foley catheter insertions, and then boom, now there's been a weakening, a diverticulum in that bladder wall, and this is all urine seen here in a diverticulum that does not drain spontaneously very well, and there's maybe some sediment or even clot here at the bottom of it. So this is something that when you see a very large bladder diverticulum, it's super easy to mistake that for a bladder, obviously, so which is why I want to remind you to fan all the way through it, look for any connections with the actual urinary bladder itself. Foley catheter placement, very straightforward in case you're not unaware of it. You place, here is an example of a male, but you would place the catheter through the penis and into the bladder. It's an uncomfortable procedure, and I've seen it performed on thousands of males, and it's like, hold on to the bed rails, here we go, kind of a procedure. Very barbaric in my mind. So, which is why I think it's important to always remember about ultrasound, because sometimes somebody might say, a nurse might say, hey, this patient hasn't put any urine out in the last 8 hours. And you go, oh, it's probably an obstruction somewhere. Just throw a Foley in there and see what comes out. That's like, imagine you're the patient, throw what? Just to see look with ultrasound and see if maybe they're not putting out urine because of another process going on. Maybe they have acute renal failure. Maybe they're dehydrated and the bladder's actually empty. But to subject somebody unnecessarily to a Foley catheter, I think, is mean, frankly, and not very patient-centric. So always remember that, to look first with ultrasound. And you can look at pre- and post-void residuals to see how well their bladder is functioning. So you know what the Seldinger technique is. If you don't, you're going to hear about the rest of your life. It's a medical procedure in which you obtain safe access into vasculature or other hollow organs, invented by Dr. Seldinger, who not too long ago passed away, actually. He was a radiologist from Sweden who developed the procedure in 1953. Basically, any Seldinger techniques involve sticking a needle through the skin into the target you're interested in, and ultrasound can be used to target the tip of the needle into anything. And then you pass, so you get the needle in there, and then you're going to put a guide wire through that needle, and the guide wire will end up in the target. And then you can remove that needle and place a dilator through the guide wire, and then you can kind of like twist the dilator around that widens that track in order to put something else like a catheter down. So then you would take the dilator out and then put a catheter down. So to review, so you put a needle in, and as you go in, you can enter it under ultrasound guidance, and then you aspirate and fluid starts to come out. Then you know you're in the target, and then you take the syringe off, and then you guide a little guide wire into it. By the way, these procedures are super fun. And then you take your needle out, and then you do the dilator, and then after the dilator comes out, then you can thread the catheter or whatever it is over the guide wire into that target, and then you remove the guide wire, and then it's just the catheter inserted into the target. That's how this works. When we do a suprapubic bladder catheter, sometimes there's contraindications to going through the urethra. Usually they're trauma. The contraindication is trauma. But if you ever had to do a suprapubic bladder catheterization, you would use the Pythagorean theorem that the right triangle, that the distance x should equal the distance x prime. That's how far back away from the center of the ultrasound probe that you would insert the needle through, as long as your needle comes in at a 45-degree angle. So if this distance between the skin line and the bladder, was 2 centimeters, you'd choke back 2 centimeters away from the center of the probe, making sure that the probe is straight perpendicular, come in at 45, and then boom, your needle tip and your sound should all be inside the target at the same time. That's the idea when you do one of these procedures, but you can also do it in the in-plane technique as well. So here we are doing out-of-plane or short-axis view with the large footprint transducer. We are advancing the needle using that Pythagorean theorem through all of this tissue. I mean, this is like 1, 2, 3, I'd say probably 4 centimeters back away from the probe. And then finally there's my needle tip as it's entered into the bladder. And then I would start the rest of the Seldinger technique, get that guide wire in there, pull the needle off, get the dilator, pull the dilator out, and then throw the catheter down the guide wire. This is the prostate seen back here on this male patient. And then once you get it in there, you inflate the balloon. Here's that balloon inflated, and we're looking with ultrasound to confirm that. And we can tug back. You inflate the balloon, and you can tug back on the catheter, and that's what holds it inside the center of the bladder. You can also measure the volume of the bladder. You can see here it measured to 580 cc's. Well, how the heck did we do that? Well, these machines have formulas in them, and it's generally speaking 4/3 pi r cubed or something. And there's different shapes of the bladder and some subtleties here, and it doesn't have to be to the exact, milliliter, but it's a pretty good idea whether somebody's got a full bladder or not when you can say, yeah, there's more than 500 cc's in there. So here you measure the transverse. In the transverse, you measure the width and the height, and you enter those in distance 1, distance 2, and then you unfreeze the machine and you move it into a sagittal view, and then you freeze it again, and then you measure the length. And there's your third dimension, and then the machine is calculating the volume for you. So then the patient would attempt to void, and then you could do this again, and you could trend their post-void residual that way. But yeah, that's basically it with back pain. Real quick here, I just want you guys to think about Uncle Dougie. Anytime somebody comes in with flank pain, groin pain, back pain, scrotum pain, syncope, and certainly anybody with a history of hypertension, tobacco use over the age of 60, again, more common in males, but I want you to really think about this diagnosis, and you may be that person who stumbles across it. We had a fourth-year medical student stumble across this week in our ER. So that was really cool. A medical student really made a huge impact on a patient's life using ultrasound. Renal colic, yeah, if the patient's colicky, they can't find a place of comfort, then you're going to definitely use ultrasound there to rule out renal obstruction. And certainly, I think ultrasound of the bladder is helpful to see if the patient's even making urine, troubleshoot catheters, and calculate post-void residuals. Thank you very much.